Hi and welcome to Physiotutors podcast episode 74. Today we're joined by Dr. Erik Thoomes, a leading musculoskeletal clinician, educator and researcher with a keen focus on neck pain, cervical radiculopathy and related spinal conditions. Erik's extensive research and publications have helped shape evidence-based practice in both diagnosis and conservative management strategies. We're thrilled to have him here to share his insights and practical guidance. Let's dive in. Hi, Erik. Welcome to the podcast.
Hi, guys. Thank you very much for inviting me. And it's an honor to be here. And the way you introduced me makes me feel slightly more important than I actually am. But thank you for inviting me.
That's the idea. No, great to have you, Erik. Hey, let's jump right in and maybe to set the stage, could you quickly explain what cervical radiculopathy is and also how it differs from more common non-specific neck pain?
That's a good question. I think it's a very common musculoskeletal classification system is one of initially separating specific from non-specific disorders, and especially in the lumbar and cervical spine, we tend to do that. And in specific neck pain, we think we know what the cause of neck pain is, whereas in non-specific neck pain, we cannot determine the cause, but only the consequences and the contributing factors. Cervical radiculopathy is a specific cause of neck pain, but a non-serious one. And non-serious, that is, as opposed to serious causes such as tumors and fractures and systemic diseases. In one of our publications, we've defined cervical radiculopathy as radiating pain into the arm of a neuropathic nature or with an in-part neuropathic quality, provoked by neck postures and neck movements with concomitant or concurrent mechanical neck pain. So it's mainly arm pain, periscapular shoulder pain, more than neck pain, but it is still labeled as a neck pain condition. And cervical radiculopathy is a clinical condition, mainly. It's associated with symptoms of shoulder pain, periscapular pain, and arm pain, as well as neck pain, but that's not dominant. And it's also associated with upper limb paresthesia and muscle weaknesses, all of which are caused by a cervical nerve root irritation or a compression orientation due to a compression. And that cervical nerve root can be caused by cervical disc herniations, but is equally common as that the intervertebral foramen has become more narrow, usually as a result of spondylotic changes. And of course, both causes can also present simultaneously. In non-specific neck pain, we can have also referred pain to the shoulder and arm region, but this is from another origin and not due to nerve root compression. And there are perhaps some similarities between lumbar radiculopathy and cervical radiculopathy, but they also have distinct different features.
Just as a quick add-on question, are you a supporter of the term or the pronunciation cervical or cervical? I know a lot of people feel strongly about this.
Well, that mainly depends on which country you're in, and it depends between Australia and England and and Canadian. And I've been blessed to have been taught by lots of English speaking tutors, and the term cervical has stuck to me. But so I'm used to pronouncing it as cervical, but we all mean the same thing, so it doesn't really matter.
I'm used to cervical, but it's then people might confuse it with the cervix. So
there is
that's the reason
difficulty
for that.
also. Yes, quite sure.
Okay, you briefly touched on differences to the lumbar area. So can you maybe give some more details of how, for example, neck herniations differ from lumbar herniations?
Yes. Well, the first obvious difference is that the cervical spine is completely different from the lumbar spine. Has a completely different function. It has different functional anatomy. For instance, the cervical spine can rotate up to 180 degrees from left to right, whereas the lumbar spine can rotate no more than approximately 70 degrees. And all this functional anatomy, again, has implications on how much the intervertebral diameter is, how large it is, and how much we can influence influence that diameter by, for instance, a rotation or side flexion. But there are certain similarities for sure. But I tend to look at the cervical spine as a separate entity. And when we do not have enough evidence, we can then always look at the lumbar spine and see if we can draw lines between the two of them. But I enjoy looking at the cervical spine as a different section from the spine as the lumbar spine.
Mm. During our masters, we always used to call, or in the cervical region, we used to call it cervical radiculopathy, while in the lumbar spine we called, we talked about a combination of lumbar radiculopathy and or lumbar radicular pain, which then fell under the umbrella term lumbar radicular syndrome. Is this the same in the cervical area, or is it different?
We would very much like that to be universal, yes. Radiculopathy in itself is not painful. We use the term cervical radiculopathy, but essentially, especially we as physiotherapists, see patients with what we would like to call a cervical radicular syndrome. And the syndrome includes the pain factor, because patients mainly come to us because they have radicular pain. And radicular pain and radiculopathy commonly occur together, but they are separate entities, and they're different. So the International Association for the Study of Pain has separated the two of them also. So we need to be as clear as possible in our terminology. So in the Netherlands, we have we're now trying to use the universal term radicular syndrome for the lumbar and the cervical spine, which then includes pain. And pure radiculopathy is something that usually only neurologists would see, and then patients would only have paresthesia or muscle weakness, but no pain.
Okay, yeah, thanks for the clarification. I was always wondering about it, if in the cervical area it's actually the same story. Hey, and moving on from an epidemiological standpoint, what do we know about the prevalence and risk factors for cervical radiculopathy, or shall I better say cervical radicular syndrome?
We really do not know a lot. The data are very limited, and they're mainly based on one large population-based study from Rochester, Minnesota in the 70s. And a recent systematic review, which tried to gather all the information, mentioned that we're still mainly relying on that one huge study by Robert Huckabee. They indicated sort of an annual incidence of approximately 107 per 100,000 for the men and 46 per 100,000 for the women. And the age group of 50 to 60 has the largest incidence. The peak of instances is usually between your 50th and 60th year. And that's about all we know, basically. And we really should copy that study if we have the time and the money.
Okay, and what are the most clinically useful tests or clusters of tests that can help us when it comes to improving diagnostic accuracy in the clinic?
Well, it's a no-brainer, perhaps. So the first and most important step of diagnosing a patient you suspect of having a cervical radiculopathy is a complete history taking. Building a complete patient profile covering all aspects and domains of the International Classification of Function, Health and Disability, ICF, that we use. Great history taking, and that should take a long time to do that in the clinic. Then we published a systematic review in 2017, and for my thesis we've recently updated that. There's not a lot of robust evidence on which diagnostic tests or provocations tests are reliable. There's all still low-level evidence, but from that study we propose to at least use the Spurling's test and all 4 upper limb neural tension tests, perhaps add the outcome of the shoulder abduction relief test or Davidson's test and the arm squeeze test for good measure. And those 4 is probably the most reliable cluster. We couldn't really use the cluster. We haven't done any calculations on it, but a good set of tests to use. And once they all add up to your clinical history taking, making your hypothesis more and more reliable, then, and if you suspect a nerve root compression, you would then need to establish either a motor dysfunction or a sensory dysfunction, because if the nerve root is compressed, you must have either a motor dysfunction and or a sensory dysfunction. So key muscle strength testing, myotomal reflexes are then important. And for diminished sensibility testing, you could use 2-point discrimination, von Frey filaments, cotton wool swabs for light touch, extensive sensibility testing. That will be the best way to go forward in the clinic.
Okay, and you also mentioned patient history is probably more, or is not probably more, but is more important than clinical testing. What would be items that can help you distinguish between normal neck pain and cervical radicular syndrome?
A typical patient with a cervical radiculopathy will usually have more arm pain than and periscapular pain around the scapular region than neck pain. He might complain of feelings of tingling and numbness in the arm and hand. Sometimes they might be able to differentiate which specific fingers are more involved than others, but that's not always the case. They usually describe their pain as sharp or shooting or stabbing, with a constant nagging pain underneath. They might have feelings of diminished grip strength or less dexterity with their fingers in buttoning small shirts and stuff. And their pain is nearly always provoked by specific neck movements or specific neck postures, which should be related to either closing the intervertebral foramen or putting more pressure on a disc.
Yeah. And how reliable and useful are our dermatomes and myotomes that we are taught?
Yes, I've been taught the same way, but recent research has nearly shoved that completely out of the window. There is so much individual change that they are perhaps a broad view of approximately in that area you're more likely to have C7 nerve root compression, but they are by no means reliable. And they only give us a broad indication.
Okay, yeah. That's also what I think we've created a couple of videos about it and wrote a couple of blogs about the topic as well, looking at the research that came out about it. So, and if you feel like you have good references or interesting articles, feel free to throw them out, because in the transcript we will add all of the references for people who really want to dive in and look up stuff that we mentioned during this podcast.
Yes, I will certainly do that. Yeah, a couple of nice studies done on the unreliability of all the old meta diagrams and stuff. Yeah.
Okay, hey, moving on to our interventions. What are treatment options for cervical radicular syndrome based on our current evidence that we have?
In my PhD studies, we looked extensively at the effectiveness of conservative management for patients with a cervical radiculopathy. One of the more interesting outcomes, I always feel, was that cervical axial traction is no more effective than a placebo. Well, so perhaps we should stop putting people in strange masks and putting weight on traction machines. The recent systematic review by Colombo et al. In 2020 has corroborated that. So I thought that was interesting. Effective treatment modalities should probably include neurodynamic mobilization, especially with safe spinal manipulative therapy techniques, and exercises aimed at both general aerobic fitness, but also targeted strength training of the deep neck flexors and extensors and specific key muscles that might have wasted in the process.
Okay. I think along the podcast, we will dive a little bit deeper into all of those individual treatment approaches.
Yeah, that would be good.
Yeah. And one thing to add to treatment in general is how should physiotherapists adapt their management strategies as a patient progresses from, say, the acute stage to subacute to chronic stages of the disease?
That's a very important question, yeah. Current evidence suggests that targeted individualized physiotherapy is the preferred first treatment option for patients with a cervical radiculopathy. And the words targeted and individualized are the key words here. There is no one-size-fits-all approach. And we've recently published a Delphi study, a nice one, which sort of outlines it. And one of the first things to consider with your patients is the stage the disorder is in. Is it in the acute or the recent onset stage? Then we need to be much more careful in not aggravating symptoms, as we are most likely dealing with a very irritable compressed nerve root.
Yeah.
And as the natural course progresses, and it is a positive course, most patients will recover. We can slowly change our interventions and slowly load the patient more and more and load the involved tissues more. And in that acute stage, I think one of the most important interventions is explaining to the patient exactly what is causing their problems, explaining that the natural cause is a positive one. Most patients gradually recovering in something like 4 to 6 months. So we need to be very careful to avoid nocebo messages, nocebo words, and just paint a positive picture. Because once patients have a clearer understanding of the mechanisms involved, they are much better suited to manage their own symptoms on a day-to-day basis, empowering them to have their hands on their own treatment process. And in order for our therapy, especially in that acute stage, to be effective, it needs to be supported with effective pharmacological pain management. Yeah. Considering there is likely an inflammation of sorts, and there is possibly an aspect of neuropathic pain, and neuropathic pain has a completely different pain management system than somatic pain. So we need to be careful in establishing which pain mechanisms are dominant. Yeah. And as far as physiotherapy treatment is concerned, in that acute stage, stretching patients, finding their offloading positions, how to diminish symptoms themselves during the day, perhaps assist them in wearing a cervical collar in the first 3 to maximum 6 weeks could help. It's something worth considering.
Okay.
Gentle neurodynamic slider techniques combined with gentle thoracic mobilization, cervical mobilization in the cervical area, mainly aimed at opening that foramen, can be effective too. And then as symptoms slowly subside in the sort of subacute stage, thoracic manipulation can be added in a safe way, and individualized exercises will now be more and more important, including motor control exercises aimed at the deep neck flexors and extensors. There is still a room for active and passive neurodynamic mobilization still. And then as the symptoms subside more and more in the sort of a chronic stage, in the latter stages, we increase our active approach. It should include targeted strength training of wasted key muscles, general aerobic fitness exercises, and still perhaps some neurodynamic exercises combined with spinal manipulative therapy as sort of getting rid of the last barriers to have a good movement.
Okay, great. Yeah, thanks for the great overview. And you also mentioned manual therapy. So you talked about thoracic manipulations. What about cervical manipulation?
It's an interesting question because there's very little real evidence support this all. So we need to look at sound clinical reasoning and clinical expertise. But I feel that we can all agree that cervical, high velocity, low amplitude thrust techniques are out of the question. There is some evidence supporting the use of thrust manipulations on the thoracic spine in cervical radiculopathy, but cervical spine, cervical spine, I think we should stay away from manipulating that. And when we use high velocity techniques on the thoracic spine, we should have safe techniques, safeguarding the position of the cervical spine while we execute the thoracic techniques. Cervical thoracic mobilization techniques, especially when aimed at opening that intervertebral foramen, can be used very effectively. And then there is some evidence to support the contralateral cervical lateral glide technique. God, that's a great word, isn't it? Contralateral cervical lateral glide. It's a sort of a combination of cervical joint mobilizations and neurodynamic mobilization. That's a great technique to use.
Yeah, so this means if a patient has nerve root compression on the right side, where would my mobilization be directed towards? So do I mobilize the right joint to
you would like to
into the
open
left direction?
Yeah, you would like to open the right joints, and your lateral glide technique should be away from the side of pain. But creating sort of a slider technique, in the cervical area, also opening the intervertebral foramen.
Mm-hmm. Okay. And when it comes to cervical manipulations, so that would be a no-go because we are afraid to further irritate the nerve root, or what would be your no-go there? What is the reasoning behind that?
Either irritating that nerve root or it's an irritated area. The nerve root is irritated, and locally we do not want to add any more pain messages or things that might cause pain. In patients with cervical radiculopathy, they usually are in a lot of pain. They have a lot of guarding of muscles in their cervical spine. I think it's nearly impossible to have a relaxed cervical spine in your hands and manipulate that in the mid-range area. It's nearly impossible. You will nearly always force something, making it a painful technique, and you want to steer away from painful techniques.
Okay. Hey, moving on to cervical motor control and cervical strengthening. What is the role of those exercises when it comes to cervical radiculopathy?
There's a huge body of evidence supporting the wasting of deep cervical flexor and extensor muscles in the presence of prolonged neck pain. I think that's one of the most researched areas in physiotherapy. And in patients with cervical radiculopathy, they fall into that category. They will have longer periods of neck pain. So somewhere in the period between the subacute and the more chronic stages, retraining of coordination and endurance of deep cervical flexors and extensors is warranted, is necessary. And then I believe it's an essential part of the longer-term management strategy. Of course, the stabilizer is a valid instrument to measure both coordination and endurance of those deep flexors. But nowadays there are also there's a lot of software out there, a lot of do-it-yourself gadgets available to support exercising patients, because it's a bit expensive to hand out stabilizers to every patient with neck pain, although some clinics do that, and it's a great way to move forward. But just lots of do-it-yourself gadgets. As home exercises, I myself use a hair headband with a laser pointer light attached to it with sort of a Velcro strap. Costs nothing, and I hand them out to patients together with plasticized sheets of figures they need to trace, and all these figures become increasingly more difficult. And that way they can also assess their joint position error and work on improving that also.
So basically, independent of the fact that patients fall into a different category of neck pain, just because they have pain for a longer period of time, their motor control is probably impaired. That's what we want to retrain.
Yeah, it's likely.
Is that fair to say?
It's likely that will happen, but again, it's like a no-brainer. You assess for it. You do not treat what you have not assessed. So you assess for, does this patient patient have diminished endurance or diminished coordination, preferably with a valid instrument like the stabilizer. And if you do assess for diminished either strength or endurance or coordination, then you manage that, you treat that. But I do have had the occasional patient with a longer history of neck pain in which I could not find any diminished strength or endurance or coordination. So then I wouldn't treat it.
Yeah,
there is no one size fits all. As I said in the beginning, there is no one size. You assess for what you treat.
Yeah, exactly. I think that's the message, and also sometimes I feel like people just maybe watch videos on YouTube, also stuff that we put out, and they feel like the cookie cutter approach can be applied because general evidence says this, but at the end of the day, it comes down to what you assess indeed. and you target those deficiencies, so to speak.
Very true. Every patient is different, and which is the fun of our work. There are similarities, but no patient is identical to another, and that makes our fun.
Hey, and as a quick side question, in the lumbar spine, especially in the acute phase, some people do see benefits when they apply exercises like the McKenzie exercise or McKenzie-like exercises with a directional preference. Do you also see this in the cervical spine?
From my point of view, less so. I find it a very useful technique in the lumbar spine, indeed. In the cervical spine, I tend to see more patients that aggravate their symptoms with directional preference exercises. And I find it very difficult in a significant number of patients to find that the directional preference that actually works. So I do use it in my assessment, but I rarely use it as a treatment option.
Yeah, it's also what I experience in the patients that I saw. That it's usually not, there's no preference so much, and there's usually an aggravation, or more often than not.
Yeah.
And then you also mentioned after, or you might want to start with motor control exercise and then later move on to higher load exercises. What sort of exercises might we prescribe for those patients?
Targeting the cervicothoracic region is very individualized. I tend to then really look at what my patient's doing on a day-to-day basis, activities in daily life. Do they have a sedentary job, or are they heavy lifters in their work? So that's very individual. Targeted strength training of wasted key muscles, which might often involve grip strength or finger strength, is something that I would use. But general strength training is very individualized.
Okay. Hey, and if we move on from treatment to patient education and self-management, from your perspective, what key educational messages or self-management strategies should physiotherapists emphasize to empower patients in their recovery?
Yeah, that's a great question. Pain education and education on the nature and cause and the prognosis are perhaps our most important and powerful treatment modalities. And I always advocate using that more often, perhaps. Perhaps it's also a hands-off technique, but I think they play an essential role in the management of all of our patients. And as I mentioned before, in the early onset stage, I think it's essential to teach patients to stop irritating and compressing their nerve root in order to avoid their continuous flare-ups. I sometimes use a log fire analogy, in which the irritated and inflamed nerve root is sort of like a burning log of wood, and the pain medication and their aggravation are the reasonably effective firefighters. And once those firefighters have reduced the log fire to smoldering embers, we need to avoid aggravating and putting fresh logs on that bed of embers, because then it will flare up to a log fire once again, and then we need to call the fire department again. So stop aggravating your symptoms, which is also why treating cervical radiculopathy is completely different from non-specific neck pain. And a key message for all patients is, as I mentioned before, it's a favorable prognosis. Most patients will recover within 4 to 6 months. Surgery is more often than not necessary. They will get better, but they need to take their time and they need to manage their symptoms. So you need to really understand what is happening in their neck.
Hey, and what are some common mistakes or misconceptions physiotherapists make in diagnosing or managing cervical radicular syndrome, and how can we avoid them?
Yeah, that's a difficult question to answer. I think one of the first diagnostic hurdles we have to cross is differentiating radicular pain due to a cervical radiculopathy from somatic referred pain in non-specific neck pain. And then non-specific neck pain, referred pain, might have a touch of peripheral increased neuromechanosensitivity, but that's not due to nerve root compression. Differentiating cervical radiculopathy from things like a thoracic outlet syndrome, the neurogenic form of that, is difficult as well. It's a hurdle. And we need to be aware of other differential diagnoses which are likely to come across, such as Parsons-Turner syndrome or neuralgic amyotrophy, as it's called. It's rare, but it's out there. Not all patients you suspect of having a cervical radiculopathy actually have that. If you hear hooves, do not only think horses, but think zebras, think deer, think other possibilities. It's a sound clinical reasoning, constantly looking at if your patient's features fit your diagnostic hypothesis. And if you find features you cannot explain, then think again and don't just jump to conclusions.
Anything else that comes to mind that you might see in practice where you feel like this is something where we commit mistakes maybe in treating the condition?
Yeah, I think we've mentioned that already. It's not a cookbook. There is no cookbook for treating any patient with any disorder, and especially not in the radiculopathy. Treating patients is not a steep lined road up ahead. It has many pitfalls. It's like a winding mountain road. You fall back sometimes. You have flare-ups. You have suddenly you feel much better, and 2 days later you might feel worse again. That's a natural process of getting better. It'll not be a straight line. And teaching patients that is normal. That is good. That's bound to happen. That's try and find out what you've done that might have caused that, but don't be alarmed if it has happened.
Yeah, you just touched on other diagnoses as well that we should consider, and I just realized that I skipped the question that I had noted down, and that's about red flags and imaging. So under what circumstances should we consider imaging essential, and what red flags should prompt immediate referral to other healthcare professionals?
I think the North American Spine Association Society, as well as the Dutch Medical Specialist Federation, have both adopted the same strategy. Imaging is not necessary unless you are unsure of your diagnosis and you feel you need corroboration of a diagnosis. If you have features that don't fit, perhaps then, and their advice is to only use imaging once you have decided that conservative therapy is not effective and you're thinking about either injections or surgery, and you want to predetermine the level your injection or your surgery might be aimed at, targeted at. But imaging really has no place in the initial stages.
Okay.
Other red flags, rapidly increasing symptoms, rapidly increasing muscle wasting, and odd behavior of pain, unexplainable odd behavior of pain. Think of the 3 main red flags, apart from all the other usual red flags we always cover. But these are, I think, the main 3 for patients with a cervical radiculopathy.
Okay. And we also briefly touched on lumbar versus cervical. Are there any lessons that we can learn from lumbar radiculopathy research or clinical practice that physiotherapists can apply when dealing with cervical conditions?
For physical therapists, we've covered that a bit. The mechanical, the McKenzie style therapy tends to be more effective in the lumbar spine than the cervical spine, from my personal point of view.
Yeah.
Perhaps not as physiotherapists, but pain management, pharmacological pain management. There's not a lot of evidence that in the cervical spine, so we tend to borrow that from evidence there is in the lumbar spine. And be aware that the cervical spine has a completely different functional anatomy, a different function in your life and in your activities of daily life than the lumbar spine. There are analogies, there are similarities, but it is a different region. So sound clinical reasoning and being patient specific with your individual patient is a lesson I think we learn from all of these things.
All right. And you've conducted quite some research in the area. Based on the gaps you've identified in the literature, where do you believe future research should focus on, and how can physiotherapists contribute to probably filling those gaps?
I think one of the things future research with respect to cervicalopathy should address is the lack of the epidemiological data. We should repeat that large population-based study Radhakrishnan did in the 70s or in 1994. We should really redo that again in a different area of the world, perhaps in Europe, and we should incorporate what we know now, how we diagnose patients with a cervical radiculopathy now, and redo that study again, because we need more epidemiological data. More studies on neurodynamic mobilization are warranted. Our current understanding is that neurodynamic mobilization is thought to improve neurovascularity, nerve movement, and restore optimal intraneural homeostasis. But there is a need for a lot of fundamental research to better gain an understanding of all the mechanisms involved and associated with why improved nerve excursions are improved with clinical outcomes.
Yeah.
And from a diagnostics point of view, one of the first things we should try and do, that there are so many ways of executing the Spurling's test. All studies that have studied the test use a different version. So we should look at which is the most effective version of it, and then universally use that one.
There is a study from Annexstein, I think in 2011, who looked at different versions. I don't know if you're familiar with that study. Yeah. So I think if people are interested, we made a video on that. So there seems to be preferred positions, but I think it's one study. So as always, we've got to be a little bit careful.
Well, I have my own ideas about that as well, and there's logical reasoning to be used, but we need to corroborate that with robust evidence, for sure. And then finally, it's a very interesting point also, we should do some research on the generally accepted and most often used neurological examinations, such as muscle strength, reflex testing, sensibility testing. Be aware that most medical doctors and neurologists only use neurological testing in their diagnostic procedures. They rarely use Spurling's test or upper lip neural tension tests. But there have only been 2 studies ever that have yet studied that neurological examination prospectively. And basically, we have no idea about the diagnostic accuracy of those procedures. So we really should study that better.
That's a good one indeed, yeah. And we already talked about different things that physiotherapists should or could consider in their practice. Do you have any maybe clinical gems to improve management of cervical radiculopathy that you would like to share that go beyond what we already discussed?
Okay, well, be proficient in the gentle use of neurodynamic mobilizations. Come up with as large a variety as you can of exercises, essentially doing all the same thing, but in different functional activities. Because I think we can generally see that neurodynamic mobilizations are an important part of the management strategy. And in the early onset stage, when there is a lot of pain, a lot of inflammation, we should use very passive and very gentle techniques and slowly increase that as time continues. Monitor for flare-ups and don't be afraid to downshift occasionally. Maybe the last one to sort of have a lot of discussion after this podcast. Avoid much of the passive modalities such as cervical traction, which you've mentioned, kinesiotape and dry needling, as there is no evidence to support their use in patients with cervical radiculopathy. Active approaches, there is evidence for that. And I know it is more difficult and more takes up much more of your time and your mind and your thinking process to be active with your patients instead of just sticking some plaster on it or pricking a needle in it. But spend time and energy in individualized and targeted specific exercises with your patients.
All right, thank you. Hey, we're coming towards the end of our podcast, and I always ask our guests, is there anything that we haven't touched on that you would like to add to the discussion?
No, I think my last comments will have made up for a lot of discussion afterwards. I think we've covered diagnosing and managing patients with the cervical radiculopathy. And I like the word managing. We're not treating them. We're managing them through their natural process. They will get better, but we can help them maybe get better faster and get better, having less chance of recurrences.
Perfect. And lastly, where can people find you if they want to reach out or learn more about you?
But perhaps, that's a difficult one. They can email me. They can always email me, and they are sure to get an answer. I'm not sure if perhaps we can post that email address somewhere, or
I'll put it in the transcript.
Put it
That's
in the
fine.
transcript. My GM address. I love my work. I love treating patients. I still do that on a day-to-day basis every day. But I do love doing research as well, and combining the two makes my life interesting every day. And I enjoy questions from colleagues. So if people email me, they will surely get an answer. It might take a few days or a week, but I answer all of my emails.
Okay, perfect. Erik, thank you so much for your time and for your insights, and it was a pleasure to have you on the pod.
Thank you for having me, and I enjoyed listening to your videos and your podcast always, so been honored to be part of one of them.
Appreciate it. And thanks a lot for listening to this episode, and to listen to this and other episodes, maybe even in your own language, including German, French, Spanish, Italian, Portuguese, and Dutch, download our new and free Physiotutors app. And additionally, if you're a premium member, you can also access the transcript and infographics and find more useful physio content. And with this being said, to add, if you enjoyed this episode, hit the subscribe button or follow our podcast on Spotify or Apple Podcasts, and consider leaving a review if you really enjoyed it. And with this being said, this was Kai for Physiotutors, and I'll talk to you in the next episode. Bye.